2. Cytokines affect the B lymphocyte. IgA is formed. Other inflammatory mediator perform a newly formed mediator. Pharmacological effect: blood vessel, airways, cell infiltration, accumulation. Clinical effect: hay fever, asthma, eczema, anaphylaxis. Clinical effect: antigen presentation, IgE production, mast cell activation, mediator release. Clinical effect: mainly antigen presentation, T0, T helper 0, interleukin 12, T helper 1, B lymphocyte, T helper 2 affect also B lymphocyte, IgG1, IgE, IgG2A. Cytokine control: depending on the site of antigen contact, release of mediator result in different clinical symptoms. In the respiratory tract, mucus production and smooth muscle contraction lead to runny mouth, watery eyes, sneezing, coughing, sinus congestion, and constricted airway. In the gastrointestinal tract, smooth muscle contraction, fluid release cause cramping, diarrhea, and vomiting. In the skin, localized swelling causes hives, urticaria. The risk of developing a type 1 hypersensitivity atopy is linked to family history and IgE level. A child risk of becoming atopic is greatly if his has parents who are atopic, he or she. People with higher IgE level tend to be atopic more often than people with lower IgE level, although the linkage is not absolute. Type 1 hypersensitivity can be measured by skin testing, prick test, or by ELISA and RAST. Immediate and delayed skin reaction, delayed response at 4 hours, immediate response at 20 minutes, 1 to 20, 1 to 100. Treatment of allergy: complete allergy avoidance. Complete allergen avoidance medication to prevent or lessen allergic symptoms include sodium chromagolicate to block mast cell degranulation, antihistamines and epinephrine to block mediator action on the tissue, immune suppressive drug like steroid to block T helper 2 activity. Topic: individual may also receive chronic desensitization. Allergy desensitization definition: it's administration of increasing dose of allergen extract to select subject suffering from IgE mediated hypersensitivity with the aim of ameliorating the symptoms associated with exposure to the causative allergen. The process is often called hyposensitization or desensitization because one consequence of the treatment is a reduction in sensitivity of the target organ after challenge with the relevant allergen. It's also called allergy immunotherapy. It's the only therapeutic modality that can affect the natural course of allergic diseases. Types of allergen extract for treatment. Extract used in allergy desensitization are either crude or partially purified aqueous extract of the common inhalant allergen. Many allergic patients have multiple sensitivities and therefore requires multiple allergen present in crude allergen extracts. Aqueous extract. Aqueous extracts are prepared from a variety of sources including pollen, molds, epidermal and insect venom. These are aqueous extracts absorbed on an aluminum hydroxide carrier to slow the release of antigen. This slow release may afford a prolongation of antigenic stimulus. Alum precipitated preparation. Alum precipitated pyridine extract. Pyridine is used to extract undefeated pollen period to alum precipitation. Pyridine extraction process appear to alter or destroy the allergenicity of the material, producing lower level of blocking antibody and less clinical benefit but fewer local or systemic reaction. Immunological mechanism of EIT. The efficacy of EIT may result from a variety of immunological modification, including the production of IgG-AP, lowering of IgG-AB, decreased sensitivity of the basophil mast cell to antigen-induced histamine release, and modulation of T cell response. Changes in the concentration of immunoglobulin E, serum allergen specific IgE level initially rises, then its level decline during the maintenance phase. Blunting of the usual seasonal rise in allergen specific IgE also occur. Immunoglobulin G, there is initial rise of IgG1 subclass, which then changed to an IgG4 response with continued IgG4 antibody has high affinity for the allergen, but from non-precipitation immune complex that doesn't fix the complement. Immunoglobulin A, IgA blocking antibodies may be detected in the serum of treated patients. Mast cell AIT in mite-sensitive children resulted in decrease in mast cell in nasal brushing. Also, grass pollen IT in adult is associated with decreased in cutaneous mast cell. In ragweed sensitive patient, conventional IT inhibit immediate release of mast cell mediator. Some investigators suggest that the number of mast cell in the skin can correlate with clinical improvement after allergy immunotherapy. Eosinophils, decrease in eosinophil recruitment into the skin and the nose occur after allergen provocation. Birch pollen in IT inhibit seasonal increase in eosinophil and ECV concentration. Basophil, several studies have shown decrease in basophil releasability for histamine and also leukotriene. Modulation of cell function. CD4 T cell subset. The goal of allergen IT is increasing seen as the conversion of the pathologic allergen specific immune response into a protective one. Immune modulation. Successful allergen IT result in reduction of the function of allergen specific T helper 2 lymphocyte and often development of allergen specific T helper 1 lymphocyte, those producing interferon alpha. T helper cells. T helper 1 send protect against allergic diseases by depending the activity of T2 helper effector cell and inhibiting IgE antibody production. IT with allergen extract result in shift from T helper 2 type to helper 1 type through stimulation of interleukin 12 production, thus promoting a T helper 1 response. Interleukin 12 cause selective inhibition of the upregulated T helper 2 immune response. Inhibition of interleukin 4 induced B cell stimulation and decrease in CD23 B cells. Alteration of cytokine pattern in the form of upregulation of interferon gamma production after ET, which might reduce interleukin secretion, thus suppressing IgE production. Late phase reaction. Allergy immunotherapy. T helper cell, interferon gamma, interleukin 5, interleukin 4, CD8 T cell and other immune regulator cell. EIT may induce allergen specific CD8 T cell or regulatory T helper cells secreting TGF-B or interleukin 10 terminate T helper 3 TR1 cells, which may be more important than T helper 1 cell in down-regulating allergic inflammation and preventing atopy in normal individual. Natural killer cell. A decrease in natural killer cell cytotoxic activity during IT is one of the modalities of action of this treatment regime. Other effect. EIT suppress the production of monocyte chemotactic and activation factor and the production of interleukin 8 and the beta chemokine that cause histamine release. It also reduces serum level of but not, and this is related to a decrease in inflammatory reaction. The effect of EIT on skin prick test. Several studies have shown a decrease in the size of the cutaneous early and late phase reaction skin test with allergy desensitization. There is significant decrease in histamine and the kinin and the prostaglandin D2 release after allergy reaction changes. Cellular influx also is significantly decreased as shown in decrease in neutrophil influx, CD4 cell eosinophil recruitment with the inhibition of the late phase response. Who will benefit from allergy immunotherapy? Allergy immunotherapy should only be considered to treat type 1 IgE mediated allergies that has been confirmed either by allergen skin prick testing or radioallergosorbent testing. Another equally important consideration is whether the patient is likely to be compliant and adhere to this regular treatment regime of 3 years. The ideal candidate is a severely allergic person who is unable to avoid the offending allergy in daily life and whose drug therapy has failed to control the allergy or in whom drug side effects have become intolerable. Indication: allergic rhinitis. There is no doubt that EIT is effective in the treatment of allergic rhinitis. Pollen-induced allergic rhinitis respond well to EIT with 80 to 90 improvement, while allergic rhinitis caused by molds is less successful than with pollen extract. Allergic asthma. EIT is established but controversial type of treatment. It's indicated when there is poor response to environmental control or pharmacological treatment. Pollen-induced asthma and mite and house dust-induced asthma. Venom hypersensitivity. EIT is treatment for choice for severe P venom hypersensitivity. It's indicated in patients with positive skin test or venom-specific serum IgE who have severe reactions, respiratory, cardiovascular symptoms. Drug hypersensitivity. Desensitization for anaphylaxis in response to drug has been successful for selected cases of penicillin and insulin allergy. Also successful desensitization of patients to vancomycin and trimethoprim sulfamethoxyl have been reported. Animal dander sensitivity can respond to EIT, however it's not recommended to be used routinely and is replaced by removal of the offending allergen, other environmental allergen, feather, jute, unstandardized house dust extract rare of questionable value in EIT generated should not be used. Food allergy. Although experimental desensitization protocols are proceed for food allergy, the risk of serious anaphylaxis has depended this material. This trial has dampened these trials. Who should not receive immunotherapy? The procedure is generally contraindicated in patients over 50 years of age and those under 5 years of age. It should not be used in patients with coronary heart disease, hyperthyroidism, autoimmune disease, malignancies. Beta blocker medication should be stopped before commencing the procedure as they interfere with the action of adrenaline if used to treat anaphylaxis. Relative contraindication are pregnancy, eczema, chronic uncontrollable asthma, food allergy, and module allergy due to lack of safe commercial available standardized extract. Treatment schedule: pre-seasonal or co-seasonal. IT given intermittently during the year. Perennial schedule. Perennial IT given throughout the year. It's either rush IT several injection in one day or traditional a weekly or twice weekly schedule. The injection of allergen extract is given subcutaneously into the outer portion of the upper arm once a week. Dosage starts to 20 SQ unit and usually increase to maintain doses of 100. The injection dose is doubled weekly until a state of tolerance to the allergen is achieved, usually at 15 weeks. Cross-pollen immunotherapy should be commenced preseasonally so as to reach the maintenance dose before the pollen season starts. Thereafter, maintenance injections are given 4 to 6 weeks for a period of 3 years to complete the immune modulating process. During the grass pollen season, we usually reduce the maintenance dose by 25%. The patient should be observed for at least 1 hour after each injection to ensure an adverse reaction doesn't occur. All forms of sport, exercise, alcohol, and hot bath should be avoided for 6 to 8 hours after all. Contact with the relevant allergen immediately after the injection should be avoided. Maximum clinical benefit usually occur within 12 to 14 months after reaching adequate maintenance dose. Relapse is possible after discontinuation if no improvement is noted after trial of 12 to 24 months. It's unlikely that additional therapy will be of value. Administration of EIT. The usual route of immunotherapy is subcutaneous injection in the deltoid region of the arm. Non-invasive route for EIT were developed. A nasal aerosol allergen IT is an alternative form of IT using an aqueous solution of allergen to spray on the nasal mucosa at a specified time interval. This form of treatment has been shown to be clinically effective. The risk of anaphylactic reaction is less than with traditional IT, and the administration is facilitated since the patient administered the extract by himself. Nasal bronchitis, congestion, and sneezing are of sufficient severity in some subjects to result in discontinuation. Local conjunctival IT with standardized dermatophagoitis extract has been tried in patients with allergic conjunctivitis. Oral allergen immunotherapy. Oral IT with birch pollen extract has been shown to be efficacious utilizing various dosage schedule. Also, dermatophagoid pharinamide in tight capsule was orally administered to adult mild sensitive asthmatic patient and showed marked improvement. Microencephalocapsulated allergen may make oral IT a practical mode of treatment. Sublingual IT is an alternative subcutaneous IT with the same rationale and indication. Trial with sublingual administration of allergen have suggested that low dose therapy with dust mite or glass maize extract is efficacious in allergic rhinitis and asthma. Outcome and benefit of successful immunotherapy. The success of immunotherapy is dependent on the patient receiving regular injections of highest tolerated dose of the biological standardized vaccine for at least 3 years. Only limited knowledge exists about the optimal duration of immunotherapy and the duration of the therapeutic response achieved, but research is continuous and successful trials are found. Grass and birch pollen allergic patients seem to derive benefit for at least 6 years after completion of the full course of immunotherapy. In our in-house dust mite allergy, the duration of clinical response may be shorter and immunotherapy may need to be recommenced at later stage. Between 7 and 17 of bivalent allergic people will relapse 1 to 2 years after completion of successful immunotherapy. Because of this small risk of relapse, it may be advisable for patients to carry emergency antihistamine or adrenaline after completing their immunotherapy. Successful immunotherapy will reduce the severity of an allergy disorder, improve the quality of life of allergy sufferer, and diminish the risk and cost of pharmacotherapy. The ideal endpoint to signify successful immunotherapy is negative skin prick test or a fall in allergen-specific IgE to negligible level. However, only a minority of patients will achieve this endpoint despite the procedure producing a good clinical and symptomatic response. What for future strategies for AIT? AIT is faced with the risk of anaphylaxis, standardization, problem of allergen extract, so more rational and safer regime are required. Allergen modification aim at modifying basal epitope in order to prevent IgE binding and effector cell cross-linking while preserving T cell epitope to retain the capacity of inducing tolerance. In this way, the modified allergen will be directed to T cell by phagocytosis, pinocytosis mediated antigen uptake mechanism, bypassing IgE cross-linkage and IgE dependent antigen presentation. Accordingly, regulation of allergen specific T cell cytokine pattern and IgE-IgG production was demonstrated by modification of three-dimensional structure of allergens. In this context, chemically modified allergen extract with low IgE binding capacity have been developed to reduce anaphylactic side effects. The progress of recombinant technique improve the ability to develop novel vaccine for treatment of allergen, deletion and mutation of decisive amino acid in B cell epitope, and fractionation and oligomerization of allergen by genetic engineering is fruitful approach to generate hypoallergic vaccine. Moreover, non-IgE binding short T cell peptide and single amino acid altered peptide ligand present potential candidate for future AIT.